is the disease known as leprosy. Okay. So do you know the Urdu name for it, or a common another name for leprosy? If you know, please write down in the chat box. Please शारिक chat open कर दीजिएगा सारा वक्त, क्योंकि फिर interact करने में आसानी होगी.
Yes, madam, chat on है.
ठीक है. Jazam in Urdu, very good. ठीक, in English, Hansen's disease, very good. So you guys know that what it is called, but it's a considerable level of stigma is attached to this disease, because it was once known as code also, and people were scared. Why they were scared? Because of the disfigurement and the ugliness, because the facial like characters were lost, and these guys, poor guys, were looked very ugly, so people used to be scared of them. So I'm telling you the history of this disease. It's very centuries old disease, and this disease was also depicted in a epic movie known as Ben-Hur, in which characters, mother and sister, were suffering from leprosy, and how they were treated, how they were kept outside the city because of this taboos and stigma attached to this disease. So you will find it in the biblical, in the Bible also, that Jesus Christ were healing those patients which were affected due to this disease. So it was not until 1874 when this Mr. Hansen, Dr. Hansen, discovered this disease, and he explained it that it is not hereditary, it is not always contracted but by just touching these patients. So it was not until 1873-74 when he described it. And another important aspect of this disease is that we cannot culture it in the laboratory through these regular type of media. We cannot culture it either in the cell culture or in the culture media. We cannot culture it. Okay? So there are, because to keep this progeny going on, there are some reservoir hosts that are present, and they were known to be 9-banded armadillo, and it is very common in some states of United States like Louisiana, Texas, and other Mississippi Delta. So this was common there, and this animal is also common there, and it carries the organism, and it was thought that this is the organism, this animal is responsible for transmitting the disease in the human being. And there is one other animal which is also responsible for the disease and was found to be carrying this organism is red squirrel, which is present in British Isles. When I'm saying British Isles, that means Great Britain plus Ireland. So it was found there. But the interesting fact is that this disease is also found all over the world, in Asia and Africa. Except for Europe, it is very it's less common in Europe, but it is widely found in US and Asia, Africa, Middle Eastern countries. So then then the question arises that what is the reservoir of infection here in Asian countries? So I have read in some papers that it is the monkey which carries the disease, but it's not written in your book. So you just stick to these two animals, that these are the reservoir infection, they carry this infection and then transmit it to human being. Okay? And because it gives the face a particular appearance, that is the folding of a skin, and it can lead to like disfigurement, and the nose can be disfigured and gives a particular person a leonine face. That's why I have kept this picture here. So in short, it was a intro, and now we are coming towards the topic. Okay, it's the ancient disease, as I told you that since centuries and even before Christ, this disease was discovered, but it was thought that by touching certain patients we will get it, and it is hereditary. So these patients were thrown out of the villages or towns where other people were living, just because of the fear of the disease. And in 1873, this Gerard Henrik Armour Hansen, he discovered that this is the bacteria which is responsible for this devastating disease, but not hereditary is not involved. So disabling, why I'm saying disabling disease? Because the peripheral organs like tips of the fingers, tips of the nose, they are shed off because this disease involves the skin and the nerves, superficial nerves are involved, and in the end, because the patient loses the ability to sense that there is a heat there, some trauma is caused, and at the end, these are shed off. Okay, that's why they will lead into clawing of the hands and other things. It spreads through nasal secretion and through skin. There are two methods because of the nasal, like when patient coughs or sneezes, they can transmit the aerosols to that particular, to other patients. Okay, and this organism, as I told you, that we cannot grow it on artificial media. Okay, only experimental animals like mouse foot pad and armadillos, we can grow these organisms there. So when it is not growing in the artificial media, now tell me how we are going to diagnose or confirm the diagnosis of these patients. Please, your answers, your replies in the chat box. अगर हम उसको लेबोरेटरी में ग्रो नहीं कर पा रहे तो हाउ वी आर गोइंग टू डायग्नोज दीज पेशेंट्स? प्लीज चैट बॉक्स में लिखिएगा. Clinical diagnosis, serology. Okay. Gram staining. Beta, we cannot grow this organism on gram staining. मैंने आपको बताया कि इसका जो sister organism है वो है Mycobacterium tuberculosis. So when we are staining the Mycobacterium tuberculosis in acid fast staining, we will do the same with this organism also. Lepromine test, बेटा Lepromine test नहीं करेंगे. मैं आपको बताती हूँ कि Lepromine test कब करते हैं. स्किन पैच टेस्ट, एसिड फास्ट स्टेट, वो तो मैंने अब बता दिया. पीसीआर, यस करेक्ट. ठीक है, ठीक है, ठीक है. थैंक यू बेटा, थैंक यू. सो वी आर गोइंग फॉरवर्ड. Causative organism. I told you they are acid-fast bacilli, pleomorphic. When I'm saying pleomorphic, means different shapes will be observed. When we will stain these organisms, we will find different shapes. And as of Mycobacterium tuberculosis, you know that it's an intracellular organism. This organism is also intracellular, pleomorphic, acid-fast, pathogenic bacteria. तो क्या क्या चीजें हो गई? Intracellular, pleomorphic, because variety of shapes are available when we will stain this on acid-fast staining, and it's a pathogenic organism. It prefers to grow at a temperature which is cooler. Overall, our body temperature is around 34, but it grows. So what it inclines to grow on the facial area, peripheral skin. When we are taking the sample, we are taking the sample from the earlobe. We'll draw some blood and skin scrapings from the earlobe, and grows in the skin and superficial nerve. It's a weak gram positive. We don't prefer this gram staining on this organism. When we are suspecting, we will do the acid-fast staining. But here, the method of staining will be modified, and I'll tell you in a while that what is a modified acid-fast staining method. Why it is difficult? So now the question arises, why it is difficult to culture? The thing is that because it's an obligated intracellular parasite, it lacks many necessary genes for independent survival. So it goes inside the cell and uses this machinery, and as we cannot grow it, we use this 9-banded armadillo or mousefoot pad for growing it. Sometimes interaction with armadillos can cause this infection. And I have mentioned here that in Brazil, they eat armadillos, so that can be one of the reasons. So when we will stain them in acid-fast staining, you will find few microorganisms up to cluster of microorganism, like here in this slide. Okay, I'll tell you. Here it's a globi. They are known as globi. Okay, and then there can be these single organism like here. Okay, you will find these. About incubation period, it has got long incubation period from 5 years up to 20 years. They can remain dormant in the body and wait for the right opportunity when the patient's defense systems are weak due to any reason. This organism, this grows, okay? So the incubation period is very long and growth is very slow. And this is the organism, it has got the longest doubling time, like 14 days. In Mycobacterium tuberculosis, the doubling time is 18 hours. Here the doubling time is 14 days. For E. coli, in 2 hours, they propagate like hugely. The plate will be full in E. coli. You inoculate the plate, keep it there, and after two hours you will see organism on the plate. But this is the slowest one. So when the organism is slow growing, you have to give the antibiotics for treatment for longer period of time. Okay, they both are connected to each other. It is one of the slowest growing organism. So we will give the antibiotic therapy for longer period of time. Epidemiology, as I told you, it has got worldwide distribution in Asia, Africa, India, Philippines, where there's so many people living together and no, they are not taking care of the hygiene because of poor resources, and sometimes it's the animals and people come across or come into contact with these animals and this disease happens, as in USA, Texas, Louisiana, and California. Okay, every year around 2 lakh people are infected with this disease. And here I have shown you the map. And in this map, I have shown you from variation from like 0 cases up to 10,000. And 0 cases is shown by light blue in color. And while these dark, like darkest blue is here, it shows that maximum number are there. And I have told you what countries are mostly involved here. 2 distinct forms of leprosy are there. One is tuberculoid leprosy and another is Lepromatosis leprosy. Tuberculoid leprosy is also known as proxybacillary leprosy, while the Lacromatos leprosy is known as multibacillary leprosy. This disease has got wide variation. The patient can come with only one anesthetic, hypopigmented, circumscribed area of skin. He can come to you, or he can come with extensive damage to the skin and tuberculoid, like tubercles on the face and all over. You must have seen such patients in busy areas, not now, but sometime before Corona. You must have seen in bazaars or like in southern area, people are sitting begging and they have got such kind of faces. I'll show you shortly. So there are another wide array of the disease you will find from one extent to another. Like it can be, lesions can be quite few, and it can be with extensive disease. How this disease is transmitted. We have to see how this disease is transmitted. They say that it's the prolonged contact with Lepromatosis, not the tuberculoid. It is the Lepromatosis patient who is the source of infection for others. Lepromatosis patient with Lepromatosis leprosy. Organism is excreted in large number in nasal secretions and from the skin. Pathogenesis, organism replicates within the skin histiocytes, endothelial cells, and Schwann cells of the nerves. Now this nerve damage, it occurs or happens through 2 pathways. One is direct contact with the bacterium, and another is damage caused by the cell-mediated immune attack on the nerves. Okay. This cell-mediated immune response to the organism limits its growth. Okay, it limits its growth. Few organisms are found in tuberculoid leprosy. You will find only few organisms, and granuloma formation with giant cells is observed. This is like diagnostic. When you will take the tissue, you will observe it. There is a granuloma formation, like here I have shown you granuloma formation with giant cells. Nerve damage is due to cell-mediated immunity. Lepromine test is positive because cell-mediated immune response is present, which comprise of CD4 positive cells and T helper type 1 cytokines. And these cytokines are interferon gamma and interleukin 2 and interleukin 12. Okay, now is the time when I should be telling you about Lepromine test. Lepromine test is just like tuberculin test. We inactivate the organism and small amount is injected intradermally, okay? And We encircle that injection site and ask the suspected patient to come back after 48 hours. If there is a positive Lepromine test or tuberculin test, there will be thickening at that area, and the area measurement also varies. In positive cases, it's a large area which is involved, like more than 10 centimeters, and in negative cases, there won't be any induration or thickening, and the area will be smaller. So in tuberculoid leprosy, only one or two lesions are present, and they will come to you with a complaint that this area is hypopigmented. The normal skin tone, the area of infection will be like sort of whitish showing area, and when you will prick with a sterilized pin or needle, there will be no sensation. So hypoesthesia, raised edges, there are no hair follicles, no sweating. And here the nerve damage is caused by the cell-mediated immunity. So here I have shown you the tuberculoid leprosy, and you can see these hypopigmented areas. There are two of them here. Hypopigmented area, you can see the normal tone here and the tone of the skin here in the involved skin. And here you can see an annular erythematous anesthetic. When I'm saying anesthetic, there is no pain sensation. Patient will, when you will prick that area with the needle, there will be no pain. Well-defined raised edges here. And nerves can they are enlarged. Now coming towards the second form, which is Lepromatosis leprosy. Here, when you will do the test, acid-fast staining, take the sample, you will see large number of acid-fast bacilli, even the clusters of bacilli, which I was telling you that they are known as globi. Cell-mediated immune response to the organism is poor, consists mainly of CD4 positive and Th1 cells. It is the cell-mediated response that causes the nerve damage in tuberculoid leprosy. Skin and mucous membrane lesions contain large number of organisms, foamy histiocytes rather than granulomas. Here in Lepromatosis leprosy, you will find the foamy histiocytes rather than granulomas. And here you will find that the Lepromine test is negative. Why Lepromine test is negative here? Because the cell-mediated immune response is poor in Lepromatosis leprosy. And another explanation for this is that in Lepromatosis leprosy, beta antiviral response to the infection, beta interferon are produced. In tuberculoid leprosy, beta antiviral interferons are produced, and in Lepromatosis, in tuberculoid, gamma interferons are produced, and in Lepromatosis, beta are produced, and they destroy the synthesis of gamma interferons. That's why the Lepromine test becomes negative. And here I've shown you an histopathological slide. You can see here there are multiple acid-fast bacilli are seen here, very minute. Please focus here. There are gram-negative acid-fast bacilli. The rods are pleomorphic rods are seen here. So I have compared this tuberculoid leprosy with Lepromatosis leprosy, which is extensive disease. There are many other diseases that will be similar to leprosy. There are other diseases, so they are in the differential diagnosis, like in necrobiosis, lipodica, morphia, late syphilis, and mastocytosis. There are other diseases that will look like leprosy, but after confirmation from the laboratory, we can diagnose these cases. Okay, now tell me, what are the presenting complaints of a patient in tuberculoid leprosy? Please answer in your chat box. जब आपके पास पहले पेशेंट आएगा तो आपको क्या बताएगा कि मुझे क्या हो रहा है ट्यूबरकुलोइड लेप्रेसी में? हाइपोएस्थीसिया, हाइपोपिगमेंटेशन, ओके, न्यू ग्रोथ। बेटे ग्रोथ नहीं नजर आएगी। हाइपोएस्थीसिया बोला जाएगा। जवेरिया, ओके। Abir, plaque like skin lesion, annular raised patches, okay. Painful nodules. बेटे पेन तो होगा ही नहीं, ये कौन बोल रहा है? पेनफुल नोड्यूल कौन बोल रहा है? नबीरा। इचिंग, बेटे इचिंग नहीं होगी। ओके, थैंक यू। Aksa, skin lesion with no sensation, very good. Patches of hypopigmentation. As I told you, tuberculoid is the milder form of the disease. There will be only 1 or 2 patches are there. They are hypopigmented because if they are on a particular region of the body, then patient feels that why they are there. Okay, they are changing my appearance or something. So they come to the doctor for treatment for these patches. They don't know whether it's painful or not until the doctor diagnose it, okay? And this is the form of the disease that responds very well. Within 1 week, the patient is not found in the bloodstream, okay? Within 1 week or 2 weeks. It's the form which is reversible. No damage has been done. But in Lepromatosis leprosy, widespread damage is already been done, and that can be corrected with a special plastic surgery or something. So it's the more dangerous form, the Lepromatosis. While the tuberculoid is the milder one, and it can respond well to the treatment, and patient is all right within no time. Lepromine skin test, an extract of Mycobacterium leprae is injected intradermally, and the induration is observed after 48 hours. I told you it is similar to tuberculin test, which is done for tuberculosis. It is similar to that. Only the extract is different. Clinical feature in tuberculoid, when TL is written, it is tuberculoid leprosy, and when LL is written, that is Lepromatosis leprosy. In tuberculoid, hypopigmented macular or plaque-like lesions are there. They are thickened superficial nerves, significant anesthesia of the skin, no hair and no sweat gland is found there. In Lepromatosis leprosy, nodular skin lesions are there, resulting in leonine facies. What happens that the eyebrows and eyelashes are also lost in this disease, okay? And there is thickening and folding, especially at the orbital region, giving a specific face to a person, okay? And after therapy, these patients develop erythema nodosum leprosum. What is erythema nodosum leprosum? We'll see what it is. And it shows that patient is responding to the treatment very well. Okay. Erythema nodosum leprosum are the painful nodules along the extensor surfaces of the tibia and ulna. There is neuritis or inflammation of the nerves, and uveitis, which is the middle layer of the second layer of the eye. There are three layers. So inflammation of the uvea, inflammation of the eye, which will lead into painful red eyes and blurring of vision. So that I was talking about in Lepromatosis leprosy, because these patients, they lose the sensation. They will, when there is trauma, they don't feel it, and that's how they can lose their fingertips. So here I have shown this, and the in this picture I have shown you that these loss of eyebrows and folding of the skin here, nostrils, sometimes they are deformed also. Loin phase of Lepromatosis leprosy. The earlobes can also be thickened and lumpy. Okay. Disfigurement results from skin anesthesia, trauma, burns, infection, secondary infection, bone resorption, loss of features, loss of nose or fingertips. Infiltration of the skin and nerves leads to thickening and folding of the skin. Single skin lesion. You must have seen in my pictures, I have written triple S, that is single skin lesion resolves spontaneously. Intermediate forms can either regress and become all right, or if they are more, they can go to other direction towards Lepromatosis leprosy. Lab diagnosis, as I told you, we cannot grow them on artificial culture media or cell culture. We need experimental animals if we want to grow them, but no need to destroy those poor animals. We can do PCRs, we can do skin, we can take skin from the earlobe, stain it through acid-fast staining and observe it in the laboratory, or PCR is done for the confirmation. Mycobacterium leprae, you can see the organism is seen here. Many organism you can observe. Triple S stand for slit skin smear. Slit skin smear, SSS. Abundant, uniformly stained, distinctly longer bacilli in clusters or globi. You can see here like this, or single organisms you can observe. These are the globi which you will observe in acid-fast staining. I am showing you multiple pictures because there can be more than one presentation, so you are able to understand what it is. So how we are going to process these suspected samples? Skin lesions, collection of the specimen is taken from the skin lesion, biopsy, skin scrapings, or nasal exudate. Usually the sample is taken from the earlobe, and then we acid-fast stain, which is modified acid-fast stain. Why we are calling it as a modified acid-fast staining? Because in Mycobacterium tuberculosis, we heat the carbol fission. After we put it on the slide, we heat it so that stain can enter into the bacteria. while here in Mycobacterium leprae, we do not heat them and we decolorize them with milder form of acid alcohol. But the other difference between Mycobacterium tuberculosis and Mycobacterium leprae is that we can inoculate and obtain the growth on Lowenstein-Jensen medium for Mycobacterium tuberculosis. We cannot do it for Mycobacterium leprae. Here what happens, what is the difference between, other differences between the staining is that we are using 5% sulfuric acid, while in acid-fast staining it is 10%. Okay, and we are not applying heat here in Mycobacterium leprae. And once the acid-fast staining is done, we can grade that slide after we observe it under the microscope. If the bacilli are 1 to 10 in 100 fields, we give it a +1. And if the bacilli are 1 to 10 in 10 fields, then +2. 1 to 10 bacilli per field is 3 plus. 10 to 100 bacilli per field is 4 plus, and 100 to 100 bacilli per field is 5 plus. More than 1000 bacilli, clumps or globi are there, then we will label it as +6. Cultures are negative. I told you why the cultures are negative, but here in serology, we can do the serology, and if there is extensive increase in IgM, it is for Lepromatosis leprosy. And diagnosis is confirmed. Diagnosis is confirmed on PCR on a skin sample. So what about treatment? How do we treat these patients? We treat it Depsone plus, is just like tuberculosis, where 3 drugs are given, and for 9 months to 12 months that treatment goes on. And I told you what is the reason behind why we are doing antibiotic treatment and multiple drugs for longer period of time, because of the slow growth of the organism. The organism is slow in growth, so we have to give the treatment for longer period of time. Depsone is the hallmark of the treatment, plus rifampicin, which is also used in tuberculosis. These 2 drugs are given for 6 to 12 months or until the lesions are free from the organism. In Lepromatosis leprosy, Depsone plus rifampicin plus clofazimine is given for 12 to 24 months. That is for 2 years this treatment continues in Lepromatosis. Okay. Prevention, how can we prevent the disease from spread? Is that isolation of all Lepromatosis patient. I told you tuberculoid is not that much infectious, it's not at all infectious, but in Lepromatosis they act as a source of infection for others. And another difference between tuberculosis and leprosy is that tuberculosis has got a vaccine, but this leprosy doesn't have. Okay. So at the end, the biggest disease today is not leprosy or tuberculosis, but rather the feeling of being unwanted. She was the lady who used to pick up patients from the footpaths or people who are homeless. She used to pick them, take them to the hospital she was working in and treat them, feed them, clean them, who are not related to her, who were not related at all to her, but she felt the pain of those patients. So I always tell you that as a doctors, we should have a compassionate heart. So who's she? Please write down in your chat box. Who's she? She was, Mother Teresa was in India, but who's she? Dr. Fao. Sidrat, thank you. Nabiha, Dr. Ruth K.M. Fao. Very good. She was the Mother Teresa of Pakistan. Originally from Germany, she was a nun, went to France. From there, she were destined for India, but because she couldn't catch the flight, missed the flight, something happened, and she landed in Pakistan and decided to live here and serve here. She is the Mother Teresa of Pakistan. Ruth Katharina Martha Fao, K.M. Fao. Very true, as one of your colleagues wrote, Catherine K.M. Ruth K.M. Fao, born in 9th September 1929 and died on 10th of August 2017. German born, devoted more than 55 years of her life to fighting leprosy in Pakistan, known as Pakistan's Mother Teresa. She contributed to the establishment of 157 leprosy clinics across Pakistan that treated over 56,780 people. And our civil hospital and Fizaya Medical College is named after her in recognition of her work to our community. So these are some of the references which I have used, different papers, and I told you about the epic movie which were made, Ben-Hur, which were made in 1959, won 11 Oscars, and at that time it was the most expensive movie of that time. At that time I was not even born. So if you want to see how these patients were treated in the past, you can go watch this movie. अब ऐसा कौन सा कोर्स होगा जिसमें आपको मूवी का बता रहे हैं कि जाके ये वाली मूवी देखें, मगर नहीं, ये भी नहीं, और आपको ये बुक का भी पढ़ना है, page 184 and 85, you have to go through this, and please write down a short note of 1 page on the pathogenesis of Mycobacterium leprae. Okay? Okay. After the onset of therapy with Lepromatosis, ENN developed. So, ma'am, ये कौन पूछ रहा है? जवेरिया. हम पहले इसे ट्रीट करना पड़ेगा. Yes, you will treat along with the treatment of leprosy. Okay. Second question, ma'am, what is borderline leprosy? We don't find globi in borderline, but there are many organisms, and I told you how to label them. If we will count the organism, on the basis of that we will label them as borderline or tuberculoid or lepromatosis. If globi are formed, definitely we will call it as Lepromatosis leprosy. Okay, Muiz, we might give thalidomide. We are not discussing beta, we are not discussing treatment here, just the pathogenesis. You will find it in your pharma classes, the treatment. I have just give you an outline, not all of it, just the outline for the treatment, so that you should know what are the drugs used. We are not discussing it in detail. Okay, any more questions? Any more questions? Please write down a note on the pathogenesis of Mycobacterium leprae. Okay, that was all for today. Okay. Any more questions? So we are completing or concluding our lecture for today. Thank you. Thank you. जी शारिक. हाँ शारिक मैंने ख़त्म कर दिया है. जी जी. Yeah, end the meeting. Thank you.